We will now turn our attention to the interpretation of heart rhythm. Step 1 was heart rate. Step 2 is the rhythm in question. On an ECG, the heart rhythm indicates the origin of the tracing. Compared to the interpretation of heart rate, the determination of heart rhythm is quite complex. Let us first turn our attention to the interpretation of normal sinus rhythm. Normal sinus rhythm is the rhythm that the majority of people are in the majority of the time. If you remember the heart's conduction system, normal sinus rhythm starts at the sinus node complex, which is in the highest, most right lateral position in the right atrium. Normal sinus rhythm means two things. First, that the heart rate is between 60 and 100 beats per minute, and second, that the origin of the rhythm is from the sinus node complex. If the rhythm is slower than 60 beats per minute, then the interpretation is sinus bradycardia. If it is faster than 100 beats per minute, then it is sinus tachycardia, as long as the origin is from the sinus node complex. So how can we determine whether or not the rhythm is coming from the sinus node? The following set of instructions deal with vectors in the heart. Since the sinus node is the highest and most right lateral position in the right atrium, then any rhythm originating from this location must move from the top of the heart down and from the right side of the heart towards the left. This is simple geometry. Therefore, when we look at lead 1 is positioned in such a way that it spans from the right arm to the left arm. Therefore, a sinus P wave should be upright in this lead. Since leads 2, 3, and AVF are all directed towards the feet and are all positive in the feet, and since a sinus P wave must move from the top of the heart down, sinus P waves should be upright in leads 2, 3, and AVF. Finally, the only lead of the 12-lead ECG which looks towards the right arm is lead AVR. Since lead AVR is positioned with its positive end of the bipole pointing towards the right shoulder, and since the sinus P wave must move from the right to the left, a sinus P wave will be upside down or inverted in lead AVR. The confirmation of the origin of the P wave from the sinus node is one of the very few uses for lead AVR. If a P wave is upside down or inverted in AVR, then it is almost certainly coming from the sinus node. The corollary to this is that a P wave which is upright in lead AVR is absolutely not coming from the sinus node. Here is a new ECG. First we will look at the heart rate. 300, 150, 100. This patient's heart rate is just under 100 beats per minute, approximately 98 beats per minute. The P wave is not upright in leads 2, 3, and AVF, and in fact is right side up in lead AVR. This P wave is not coming from the sinus node complex. This rhythm represents ectopic atrial rhythm. When this rhythm runs at a rate faster than 100 beats per minute, it would be called ectopic atrial tachycardia. Remember that vectors are the most important tool to help in localizing the origin of a rhythm, whether it is in the atria or the ventricles. Let's take a few moments and review what we have learned already. Simply by understanding the heart rate and by looking at the vector of the P wave, we have already learned 5 different rhythms: sinus bradycardia, normal sinus rhythm, sinus tachycardia, ectopic atrial rhythm, and ectopic atrial tachycardia. Here is a new ECG for analysis. As always, let's start with heart rate. 300, 150, 100, 75, 60. The heart rate is slightly lower than 60 beats per minute, around 55 beats per minute. Therefore, we know that this is a bradycardic rhythm. Next, let's look for the P wave. As we look in front of each QRS, it is very difficult to find a consistent and predictable P wave. There is no apparent organized atrial activity which is present in front of each one of the QRS complexes. This rhythm represents junctional rhythm. Junctional rhythm means that the origin of the rhythm is from the AV node itself rather than from anywhere in the atria. The sinus node is not firing, and the next most likely source for automatic activity is the AV node itself. Junctional rhythm is frequently slow, in fact slower than 60 beats per minute. This is a typical and classic ECG for junctional rhythm. Almost all of the rhythms that we have looked at so far are extremely regular in nature. I want to spend a few minutes now talking about irregularities in rhythm. The most common irregularities are isolated irregularities. By this, what I mean is that the R to R interval, or the P to P interval, is generally quite regular, but every once in a while an early beat occurs. These early beats are easily seen with the eye and do not require a set of calipers in order to identify. The most common causes of these isolated irregularities are premature beats in the atria or the ventricles. When a premature beat occurs in the atrium, it is called a PAC, or a premature atrial contraction. When the same phenomena occurs in the ventricles, it is called a PVC, or a premature ventricular contraction. PACs and PVCs are completely normal. Everyone has these beats multiple times throughout the day. They are not a cause for concern. However, they do catch your eye because they cause an irregularity in an otherwise smooth tracing. Here is a tracing with some visual irregularities. As you look across the ECG, you will notice that there is a pattern. PR, PR, and then a beat which is early. PR, PR, and then a beat which is early. The early beat is a premature atrial contraction. Look at the shape of the P waves in front of the regular beats. This is a sinus P wave. However, the P wave in front of this early beat is different from the other two. This represents atrial trigeminy. Every third beat is a premature atrial contraction. Again, this type of behavior and this pattern are completely normal, but it is the most common cause of mild irregularities in the ECG tracing. The correct interpretation of this ECG would be normal sinus rhythm with atrial trigeminy. Let's look at this tracing. The rate is 300, 150, 100, 75, approximately 75 beats per minute. The P waves are upright in 2, 3, and AVF and inverted in AVR. This is normal sinus rhythm, normal rate, normal origin for the P waves. As we look across the entire tracing, everything looks normal until we get to the very last beat at the farthest right side of the tracing. This beat occurs early and is different from the other beats. The QRS interval is markedly wider than that of the other QRS complexes. It is a different shape and pattern entirely. Our choices here are that this represents a premature atrial contraction or a premature ventricular contraction. If we look in front of the QRS, a PAC should have a P wave in front of it, but a different shaped P wave than those present in front of all of the other QRSs. There is no apparent P wave in front of this QRS. That, combined with the wide nature and unusual morphology for this beat, confirm that this is a premature ventricular contraction. The ventricles have fired early and out of sequence. This appearance is normal and not a cause for concern in any way. The correct interpretation of this ECG would be normal sinus rhythm with a PVC. This tracing has an easily discernible pattern to it. You will notice that there are P waves and QRSs which are normal, alternating with wider QRSs. The wide QRSs are all identical to each other, and the narrow QRSs are also all identical to each other. These occur in a pattern: the normal beat followed by the wide beat, then the pattern repeats. As we look at the wide beat, it is clearly occurring early or prematurely. There is no apparent P wave in front of these wide beats, but there is an easily identifiable P wave in front of the narrow beats. The wide beats represent premature ventricular contractions. Since they are occurring on every other beat, the correct interpretation of this rhythm would be normal sinus rhythm with ventricular bigeminy. Bigeminy refers to the every other pattern. This ECG is similar to the tracing we looked at several ago of atrial trigeminy, where every third beat was a premature atrial contraction. The correct terms for these are bigeminy when it is every other beat, trigeminy when it is every third beat, and quadrigeminy when it is every fourth beat. We generally do not refer to patterns past every fourth beat. So far we have reviewed the most common rhythm, which is normal sinus rhythm. We have reviewed the most common causes of mild irregularities in the R to R interval, which are called PACs and PVCs. Sinus arrhythmia, which is actually a misnomer. Arrhythmia in Latin means the absence of rhythm. Dysrhythmia means an abnormal rhythm. However, sinus arrhythmia is the most common term for what we are about to review. As the respiratory rate changes, patients' sympathetic and parasympathetic tone change. The sympathetic tone is the adrenaline-based system of the body. The parasympathetic tone is the opposite. These two systems are always in a tug-of-war battling with each other. As we breathe in and out, fluctuations occur in that tug-of-war, and one side begins to win over the other. The younger and more healthy a patient, the more dramatic the evidence for sinus arrhythmia. Sinus arrhythmia is merely a visible change in the sinus node rate as the patient breathes in and out. It is not abnormal, but is frequently noted and interpreted on an ECG. Let's review this tracing. As always, start with heart rate. 300, 150, 100, 75, 60, 50. This heart rate is approximately 52 beats per minute. So this is a bradycardic rhythm. We now look at the origin of the P wave, if there is a P wave. There is in fact a P wave in front of each QRS complex. It is upright in lead 2. This P wave is actually inverted in 3, but upright in AVF and inverted in AVR. This still represents a sinus origin. Lead 3, because of its angled placement against the right lateral part of the heart, can sometimes show an inverted P wave even in sinus rhythm. The sinus node complex is approximately 1.5 centimeters long. P waves which come from the lower part of that complex are generally slower. Sometimes P waves originating from the lowest portion of the sinus node complex can have an inverted appearance in lead 3. They should still be inverted in AVR and upright in leads 2 and F. This represents sinus bradycardia. But in addition to sinus bradycardia, note that the R to R intervals are fluctuating. The first R to R interval is longer than the second, and the second is shorter than the third. This pattern fluctuates across the ECG tracing. If we had been present when this ECG was recorded, we would have noted that these fluctuations are occurring as the patient breathes in and out. The correct interpretation for this ECG is sinus bradycardia with sinus arrhythmia. Before advancing further into abnormal rhythms, we must first review the mechanisms by which abnormal rhythms are created. There are two general mechanisms by which abnormal rhythms can be generated in the heart. The first of these we have covered already and is the subject of abnormal automaticity. Ectopic atrial tachycardia multifocal atrial tachycardia. PVCs and finally PACs are all examples of enhanced or abnormal automaticity. Each of these rhythms is generated from a single spot in the heart that is capable of automatic behavior. In other words, the spot is capable of generating its own depolarization. In the case of multifocal atrial tachycardia, of course, there are more than one foci which are operating concurrently. Additionally, PACs and PVCs can come from multiple different origins. In the case of ectopic atrial tachycardia, it is a single focus of automaticity which is generating the problem. The second mechanism of abnormal rhythm creation is reentry. Reentry is very much like a dog chasing its tail. The rhythm in question has entered an abnormal circuit which should not be present. That circuit forms a loop or circle, and the rhythm once in this loop or circle is a self-fulfilling rhythm. The rhythm spins around the circuit over and over and over again until some external force causes the rhythm to stop. Now that we have an understanding of the two major mechanisms for abnormal rhythms, let's turn our attention to two rhythms which mimic sinus tachycardia. Both of these rhythms are generated from within the sinus node complex. The first is called sinus node reentrant tachycardia, and the second called inappropriate sinus tachycardia. Since both of these rhythms originate from within the sinus node complex, they will both have P waves which appear to be sinus in origin. The P waves will be upright in leads 2, 3, and AVF, and inverted in lead AVR. Let's now take a look at this ECG. The patient's heart rate is 300, 150, 100, slightly faster than 100 beats per minute, approximately 115 beats per minute. The P waves are upright in leads 2, 3, and AVF, and inverted in AVR. This is sinus tachycardia. This particular 12 lead is obtained from a person with inappropriate sinus tachycardia. Inappropriate sinus tachycardia is an automatic mechanism just like sinus tachycardia. The term inappropriate applies to the trigger. In other words, it is appropriate to have a heart rate greater than 100 beats per minute if you are exercising, such as running in the New York Marathon, or if you are sick or have a fever or have been frightened. These are all appropriate reasons to have sinus tachycardia. Patients with inappropriate sinus tachycardia had the exact same mechanism for their heart rate. However, it is not driven by an appropriate physiologic cause. The only way to distinguish inappropriate sinus tachycardia from appropriate sinus tachycardia is to look at the patient's other physical conditions. If none of the normal triggers for sinus tachycardia are present, then the patient has inappropriate sinus tachycardia. Therefore, the diagnosis of inappropriate sinus tachycardia cannot possibly be made on a 12-lead ECG. The appropriate interpretation for this rhythm is sinus tachycardia. Sinus node reentrant tachycardia will form an identical P wave to this one. The mechanism for sinus node reentrant tachycardia is again built into the name itself. Reentry, or an abnormal circuit, is present within the confines of the sinus node complex. The circuit forms a loop inside the sinus node, which, once it begins, spins around very rapidly, each time sending out a sinus P wave. This rhythm cannot be distinguished from sinus tachycardia, whether appropriate or inappropriate, on a 12-lead ECG. Therefore, even if sinus node reentrant tachycardia is the actual diagnosis, the ECG interpretation is again sinus tachycardia. Let's now review the steps of rhythm interpretation that we have learned so far. First, check the heart rate. If the heart rate is between 60 and 100 beats per minute, then we know we do not have bradycardia or tachycardia, regardless of the origin. If the rhythm is extremely regular in nature, and there is a P wave in front of each QRS, then this is almost certainly sinus rhythm, but we can confirm that presence of sinus rhythm by looking at the shape of the P wave. If the P waves are upright in 2, 3, and AVF, and inverted in AVR, then this is normal sinus rhythm. If the P waves are right side up in AVR, then this is an ectopic atrial rhythm. If there are premature beats scattered throughout the tracing, or even one premature beat, it is likely a PAC or a PVC. We then look at the beginning of this premature beat. If there is a P wave in front of the QRS and the P wave is unusually shaped, then this is a PAC. If the QRS is wide and there is not a P wave in front, then this is a PVC. Let's now turn our attention to two very irregular rhythms. Unlike PACs, PVCs, and sinus arrhythmia, the following two rhythms are completely irregular, almost chaotic in appearance. These two rhythms are atrial fibrillation and multifocal atrial tachycardia. In atrial fibrillation, the sinus node is no longer firing. Signals are originating in multiple parts of the left and right atria. In the graphic on the left, normal sinus rhythm is depicted. You can see that the signal starts at the top right of the heart and spreads evenly through both the left and right atria. This even spread causes contraction of the left and right atrium in a coordinated fashion, squeezing the blood out of these chambers and into the ventricles below. In the graphic on the right, atrial fibrillation is depicted. You can see that the spread of electricity through both the left and the right atria is chaotic and not organized. This causes the atrial chambers to not contract in a coordinated fashion, and the blood is therefore not efficiently emptied from these chambers. The rhythm is extremely irregular and chaotic in nature. The actual rate of atrial contraction is approximately 600 beats per minute. However, the lower chambers cannot respond at that rate due to the decremental conduction properties of the AV node. The ventricles therefore go at a slower rate than 600 beats per minute. AV nodes that are healthy, generally found in younger patients who are adrenergic, go extremely fast, and atrial fibrillation frequently causes a ventricular rate between 150 and 220 beats per minute. The older the patient becomes and the more unhealthy the AV node, the slower the ventricular response. Slowing of the ventricular response can also be achieved by the use of medication. Do not depend on the rapid response of the lower chamber to tell you that a rhythm is atrial fibrillation or not. Atrial fibrillation is defined by two hallmarks. The first is that the R to R interval is completely irregular. No two R to R intervals will appear the same. Additionally, there is no repetitive organized atrial activity. If both of these features are identified, then the presence of atrial fibrillation can be confirmed. In this tracing, the first thing you should notice is the variable R to R intervals. The R to R intervals, as we look across this 12-lead ECG, are highly variable from one another. The average heart rate is slightly higher than typical. It is difficult to determine heart rate when the R to R intervals are this irregular. However, the first third of the ECG has R to R intervals which are fairly predictable. Therefore, we can take a heart rate from this section of the ECG, 300, 150, slightly lower than 100 beats per minute. So the heart rate across this ECG appears to be in the high 90s. We then look for the rhythm. The highly variable heart rate should indicate that this is probably atrial fibrillation. Really, all we need to do here is to confirm that that is the correct rhythm interpretation. As we look for one P wave in front of each QRS, we see that that does not hold true. As we look at V1, we see a very unusual baseline between each of the R to R intervals. There is no organized, predictable, and repetitive atrial activity across this tracing. This ECG clearly shows atrial fibrillation with a controlled ventricular response. Here is a new ECG tracing for us to examine. 300, 150. This heart rate is approximately 140 to 150 beats per minute. The R-to-R intervals are irregular across the ECG tracing, and there appears to be no repetitive pattern to the irregularity. We would suspect from the outset that this ECG represents atrial fibrillation with a rapid ventricular response. It is important to note that the faster the ventricular response becomes, the harder it is to identify the irregularities in the R-to-R interval. This happens because as the heart rate becomes faster and faster, the irregularities become smaller and smaller. When the heart rate is controlled with atrial fibrillation, the irregularities are wide and can be easily seen with the naked eye. As the heart rate increases, the irregularities may be more difficult to detect with the eye, but are easily noted with calipers. We look in front of each QRS for a predictable and organized atrial activity in the form of a P wave. As we look across V1, which is an excellent lead to look for atrial activity, we cannot see any organized and predictable P wave across this tracing. The baseline between each RR interval is unusual. This represents atrial fibrillation with a rapid ventricular response. The second widely irregular rhythm that we should talk about is multifocal atrial tachycardia. The physiology of the rhythm is present in the name itself. It is an ectopic atrial tachycardia. However, it has multiple foci of origin, hence the name multifocal atrial tachycardia. Imagine the sinus node is like a bus driver. It sets the heart rate and takes the bus or the heart down the road at the set and desired speed. Multifocal atrial tachycardia is similar to having multiple hijackers scattered throughout the bus, and periodically each of them takes turns driving the bus, each at its own predetermined rate. There are multiple drivers for the rhythm. Unlike ectopic atrial rhythm, which is a single hijacker on the bus driving at a single rate, multifocal atrial tachycardia has multiple different P waves. The classic definition of multifocal atrial tachycardia requires the presence of at least 3 separate and distinct P waves within a 6-second interval. Tachycardia, of course, requires that the heart rate be greater than 100 beats per minute. In this tracing, we can see that there are indeed multiple different P waves present. This rhythm is typical and classic multifocal atrial tachycardia. The first 2 types of supraventricular tachycardia that we looked at were both irregular. These rhythms were atrial fibrillation and multifocal atrial tachycardia. If the heart rate is greater than 100 beats per minute, and the R-to-R intervals are regular and very predictable in nature, then we can move on to the regular forms of SVT. There are several indicators that we can use to determine the origin of the regular SVTs. The first of these is heart rate. Let's examine this 12-lead ECG. The heart rate here is 300, 150, almost exactly 150 beats per minute. Anytime an SVT is going at nearly 150 beats per minute, it is very important to consider the rhythm of atrial flutter. Atrial flutter is a reentrant rhythm. In other words, it is a circuit which is present solely in the right atrium. The rhythm goes down the lateral wall of the right atrium and across the bridge of tissue between the inferior vena cava and the tricuspid valve annulus, then up the interatrial septum. This rhythm almost always circulates at 300 beats per minute in the atrium. Since the AV node has decremental conduction properties, the AV node cannot withstand conduction at 300 beats per minute. However, every other beat can propagate down to the ventricles. That means that the ventricular rate in atrial flutter must always be some even factor of 300. In other words, the heart rate in atrial flutter will divide easily into 300 beats per minute. The choices, therefore, are 150, 100, 75, 60, 50, just like the numbers we use to count off heart rate. Therefore, once a rhythm is going at one of these very specific and fixed heart rates, we should look to see if there is atrial activity at 300 beats per minute. If we look at this ECG, you can see that here in lead 2, very visible inverted P waves are present at exactly twice the ventricular rate. The atrial activity is going at 300 beats per minute. This is classic and typical atrial flutter. When more than one P wave is present for each QRS, yet the atrial rate is markedly slower than 300 beats per minute, usually between 180 and 250 beats per minute, then the usual explanation for this phenomenon is a rhythm called intra-atrial reentrant tachycardia. This rhythm is abbreviated IART. This rhythm is also a reentrant rhythm. However, it is not circulating along the route normally prescribed by atrial flutter. It is occurring somewhere else in the atrial tissue. The circuit is reliable and predictable and repetitive. In other words, the electrical conduction pathway is the same for each turn of the rhythm, so that the P waves always look the same. However, the reentrant loop is not going through the bridge of tissue between the inferior vena cava opening and the tricuspid valve annulus. This rhythm is most commonly seen in patients who have had open heart surgery. The next most common SVT that you will encounter after atrial fibrillation and atrial flutter is AV nodal reentrant tachycardia. This rhythm is most commonly abbreviated AVNRT. This is a reentrant rhythm as is defined by its name. The reentrant circuit is within a branching connection of the compact AV node. Instead of a single connection between the atria and the ventricles, people with this rhythm have a Y-shaped connection in the compact AV node. Early in life, this pathophysiology does not short-circuit. As the patient ages, the electrical properties of the two connections begin to diverge from one another. When they are divergent enough, then a short circuit can happen. The rate of this rhythm is most often between 160 and 190 beats per minute. Therefore, when you see a regular SVT running between 160 and 190 beats per minute, think of AVNRT. Let's turn our attention to this 12-lead ECG. Note that the heart rate here is approximately 300, 150, approximately 165 beats per minute. We now look for atrial activity. As we look carefully, it is very difficult to see organized atrial activity. However, the R to R intervals are very regular. Therefore, this is not atrial fibrillation. Look carefully at lead V1. Note that on the very end of the QRS complex is a small bump. This small bump in this particular rhythm is actually termed a pseudo R prime. It is called a pseudo R prime because that bump is not actually part of the QRS complex. That bump is actually the P wave. This finding is pathognomonic of AVNRT. Pathognomonic means that when present, it is a defining characteristic of AVNRT. However, all ECGs demonstrating AVNRT do not necessarily have this pathognomonic finding. Therefore, if you see a pseudo R prime in a regular SVT running between 160 and 190 beats per minute, it is definitely AVNRT. However, the absence of that pseudo R prime does not mean that this is not AVNRT. The final SVT that we will examine is the SVT that involves a separate connection across the atrioventricular groove. 1 out of every 1,000 patients are born with not just one connection between the atria and the ventricles, but rather 2 or more. Whenever 2 connections are present across the atrioventricular groove, then a short circuit can happen. The most common short circuit happens when signals go down the AV node and through the His-Purkinje system, then travel through the ventricles and backwards over the extra connection back into the atrial tissue. Once the signal gets back into the atrial tissue, it can circle around and re-enter the AV node. Now a reentrant loop is set up. This reentrant rhythm is called orthodromic reciprocating tachycardia. This rhythm almost always runs at rates between 190 and 250 beats per minute. Therefore, when a regular SVT is identified with rates between 190 and 240 beats per minute, orthodromic reciprocating tachycardia should be the first rhythm we think of. Here is a 12-lead ECG showing a very rapid SVT. The R to R intervals are extremely regular, and the rate here is approximately 250 beats per minute. When we look for P-wave activity, it is apparent, particularly here in lead V1, that there is a deformation not consistent with a normal T wave. This bump is in fact atrial activity and is the P wave. P waves in orthodromic reciprocating tachycardia are found somewhere between the very end of the QRS complex and the end of the T wave. They are most commonly found within the ST segment, just as this P wave is manifesting. Whenever we see a regular SVT with rates between 190 and 250 beats per minute, look for P wave activity in the ST segment. If we find it, just as in this 12-lead ECG, then that is entirely consistent with orthodromic reciprocating tachycardia and is short-circuiting because of the presence of an accessory pathway across the atrioventricular groove. Before we proceed to the final two rhythms which you may encounter when interpreting a 12-lead ECG, let's review what we have learned so far. Normal sinus rhythm is a rhythm which originates in the sinus node complex and has a rate between 60 and 100 beats per minute. Sinus P waves are upright in leads 2, 3, and AVF, and inverted in lead AVR. Ectopic atrial rhythms have P waves which do not originate in the sinus node, and therefore the shape of the P wave is different than just described. The P wave in ectopic atrial rhythm is frequently upright in lead AVR or inverted in leads 2, 3, and AVF. If an ectopic atrial rhythm is running faster than 100 beats per minute, it is called ectopic atrial tachycardia. Mild irregularities in the rhythm are usually driven by premature atrial or ventricular contractions. Severe irregularities in heart rhythm are usually driven by one of two rhythms, atrial fibrillation and multifocal atrial tachycardia. Atrial fibrillation is defined by a completely inconsistent and irregular atrial activity, whereas multifocal atrial tachycardia has 3 or more P waves scattered across the 12-lead ECG. However, there are clear and distinct P waves, one in front of each QRS. The regular SVTs will always have at least one P wave for every QRS. Atrial flutter is a rhythm which runs at 300 beats per minute in the right atrium. Therefore, the ventricular rate is a factor of 300, frequently 150 or 100 beats per minute. The atrial rate is almost exactly 300 beats per minute in typical atrial flutter. When more than one P wave is present for each QRS, but the atrial rate is markedly slower than 300 beats per minute, usually between 180 and 250 beats per minute, then this rhythm is usually driven by intra-atrial reentrant tachycardia. This is a reentrant rhythm within the atrial tissue. It is just not circulating along the route normally prescribed by atrial flutter. AV nodal reentrant tachycardia runs between 160 and 190 beats per minute, and the P wave, when it is visible, is present at the very end of the QRS complex and is frequently manifested as a pseudo R prime in lead V1. Orthodromic reciprocating tachycardia is the rhythm which is present because of an accessory pathway. That rhythm circulates between 190 and 250 beats per minute, and the P wave is going to be present in the ST segment. The final two rhythms which you must be prepared to correctly interpret on a 12-lead ECG are rhythms that are paced and rhythms which originate in the ventricle, otherwise called ventricular tachycardia. When we are looking at electronically paced rhythms, we are only interested in whether the pacemaker has one or two wires. A single lead pacemaker generally paces only the ventricle. A dual chamber pacemaker paces both the atrium and the ventricle. The typical manifestation of an electronically paced rhythm is that an electronic pacing spike is present right before the depolarization of the chamber in question. On this 12-lead ECG, look carefully at lead 2 running across the rhythm strip at the bottom of the tracing. We can see that right before the P wave is a tiny electronic pulse. That is the electronic pacemaker delivering an impulse which causes the atrium to depolarize. Therefore, there is definitely at least one wire in this electronic pacemaker. It is important to note that the shape of the paced P wave has nothing to do with the shape of a P wave from the sinus node. That is because the wire which is driving the P wave in the atrium is not generally placed near the sinus node complex. Therefore, it is unimportant what the shape of the P wave is when we are looking at paced rhythms. If we move our eyes then to the QRS, we see that a similar electronic impulse is present right before the wide QRS, which is present following the impulse. This is a typical dual chamber pacemaker. The rhythm should be correctly interpreted as dual chamber pacing. The final rhythm which we may encounter on a 12-lead ECG is that of ventricular tachycardia. Ventricular tachycardia, unlike every other rhythm we have discussed so far, is driven primarily by the ventricles. In every other rhythm, the ventricular rate is being pulled along by signals which originate above the level of the AV groove, in other words, in the atrial tissue. In ventricular tachycardia, the ventricles are the source of the rhythm itself. Ventricular tachycardia can be present for both reentrant and automatic reasons. However, regardless of its mechanism, these rhythms are all correctly interpreted as ventricular tachycardia. The hallmark of ventricular tachycardia will be that the QRS is wide and unusual looking, and that there is either no relationship between atrial activity and ventricular activity, or that the atrial activity is following along behind the ventricles rather than in front. The heart rate on this 12-lead ECG is extremely rapid, 300, 150, approximately 125 beats per minute. The QRS complex is wide and unusual looking. If we look carefully, we can see that there are P waves which are not associated with the QRS complexes. The atrial rate is slower than the ventricular rate. This is classic and typical ventricular tachycardia. Further information about the details of differentiating ventricular tachycardia from supraventricular tachycardia can be found in our more advanced ECG interpretation course.